Hello and welcome to today's IAC webinar. This is Chris VandenBussche. I am the co-host along with Dr. Christina Zioga, who is live tweeting this webinar. So welcome. We're very honored today to have Dr. Veronika Kloboves Prevodnik from Slovenia. She's also a good friend of mine, so I'm very honored to have her speak to us today on the topic of FNA and multidisciplinary approach of lymphoma diagnostics. She trained at the medical faculty at the University of Ljubljana in Slovenia, and she completed her pathology training there. She also has completed additional training in molecular pathology, flow cytometry, as well as additional training in hematopathology, and also has some interest in cervical cancer screening. She currently serves as the head of Department of Cytopathology at the Institute of Oncology since 2015. I would like to then turn the presentation over to her. Thank you.
Hello, everybody. Thank you, Christopher, to invite me to this webinar. Se pa ne gre prezentacija boja. Ne moram premikati slajdov, kaj pa se to? I'm coming from Slovenia. Basically, I live in Škofja Loka. This is a small old town, about 25 kilometers from capital city of Ljubljana, where I worked. I worked at the Institute of Oncology, Ljubljana. This is a comprehensive cancer center with modern laboratory diagnostic, imaging, surgery, internal oncology, radiotherapy, palliative care, clinical nutrition, psycho-oncology, genetic counseling, and also we are dealing with education and research. We have 4 laboratory departments: Department of Hematology and Biochemistry, Cytopathology, Histopathology, and Molecular Pathology. Cytopathology at our institution and also in Slovenia has a long tradition. In our hospital, the first recorded report of final of cytology examination dated on 1952, and we started with final aspiration in 1959. Today, the Department of Cytopathology is a modern laboratory. Last year, we examined about 8,900 final aspiration samples. Among them, we obtained about 4,800 samples at our FNA clinic. We also examined about 5,600 non-gynae exfoliative cytology samples, about 21,000 pap smears. In our diagnostic, we use ancillary techniques. Last year, we performed about 6,600 immunohistochemical markers and performed flow cytometric immunophenotypic in about 1,700 samples. Among them were about 900 final aspiration lymph node samples. We also performed triage test, APV test for cervical cytology. At the Institute of Oncology, Ljubljana, Lymphoma Diagnostics has a long tradition. As in other Western countries, also in Slovenia, the lymphoma diagnostic is nowadays based on the latest WHO classification of tumors of hematopoietic and lymphoid tissues. For the diagnosis, we use the clinical features and also the features of lymphoma cells, such as morphology, immunophenotypic features, and molecular and genetic features. In our institution, we use for lymphoma diagnostic both cytopathology and histopathology. In the primary lymphoma diagnostic, in most patients where lymphoma is suspected, we use cytopathological examination first. On the basis of our result, then biopsy and histology is performed and planning of the treatment. For the staging, especially in bone marrow samples, and for determination of predictive factors, we use both cytopathology and histopathology. However, for confirmation of recurrent disease and evaluation of treatment response, we use mainly cytopathology. As you have already heard, we use both cytopathology and histopathology for lymphoma diagnostics. Therefore, a lot of patient has two diagnoses, and sometimes the cytopathological and histopathological diagnoses are discordant. And the clinicians are, of course, confused because they don't know which diagnosis is correct. You may assume that histology is also right, but I can assure you that cytopathological diagnosis is not necessarily wrong. Because of this situation, we started in 2009 with the Hematopathology Multidisciplinary Board. First, we discussed the bone marrow aspiration and core biopsy result, which are discordant, but in last few years we also present all cases of primary lymphomas with discordant result. We meet once per week, and at that board participate pathologists, cytopathologists, flow cytometric and molecular scientists. And also clinicians. We re-examine all clinical data, the peripheral and bone marrow cell count and the differential count, the result of cytopathological examination, flow cytometry, histopathology, and molecular data. We discuss these results and then we make a final diagnosis which is sent to hospital information system, and it is available for all clinicians. There is a lot of benefits of this kind of approach. Our lymphoma diagnoses are more accurate, which allow optimal planning of treatment and better treatment response. There is also possibility to share knowledge between the experts from different specialties, and of course, this approach can also education and quality assurance benefits. Final aspiration and cytopathological diagnostic of lymphomas at the Institute of Oncology has more than 30 years of tradition. It is based on the diagnostic, cytopathological diagnostic of lymphomas is based on cell morphology and results of ancillary techniques. The method is well accepted among our clinicians and also among other hospitals in Slovenia. However, it was not always like that. About 25 years ago, we had a lot of discordant cytopathological and histopathological diagnoses. Therefore, our clinicians and pathologists raised the question, should cytopathological examination still be used in the diagnostic evaluation of lymphoma patients? At that time, we had a lot of discussions, we argued a lot, but finally, we decided to perform a prospective study. The aim of the study was to decide which ancillary technique, immunocytochemistry or flow cytometry, will help to make a more accurate cytopathological diagnosis of lymphomas. In the study, we included 32 cases of lymphomas and 3 cases of lymphadenitis. Here you see the correlation coefficients for the results obtained by immunocytochemistry and flow cytometry. Here are the markers we tested. And you see that for lineage markers for B cells and T cells, and also for surface lambda line change, the correlation was not good. And when we look for light chain restriction, you can see that by flow cytometry with 2 colors, at that time we found a restriction of light change, which is in favor of lymphoma in 70% of cases, but by immunocytochemistry only in 45% of cases. We conclude that flow cytometric method is more sensitive and specific than immunocytochemical method, and that's why we bought the first flow cytometer with 2 colors. The year 1997 is therefore considered as the beginning of flow cytometry, flow cytometric immunophenotyping, and modern cytopathological diagnostic of lymphoma at our hospital. At the beginning, we had a lot of problems. First of all, more than half of cytological samples have too few cells to perform flow cytometric measurements. We have also problems with the interpretation of the results. We don't know what it means when the surface light change are negative, what to do with cases where we found two populations of CD3 positive T cells. And the problem was also that the sensitivity of lymphoma detection at the beginning was unsatisfactory. Therefore, we first made connections with experts in the flow cytometry in United Kingdom, who helped us to set up the flow cytometer, to teach us about compensation, quality assurance, and also help us to build the first antibody panels. In addition, we performed also a lot of studies, and these studies resulted that we made an in-house protocol for final aspiration samples, preparation for flow cytometry. This protocol prevents cell loss during sample preparation and also allows us that we perform the analysis from 150 cells per tube. To increase sensitivity, we also upgrade cytometer from 2 to 4 colors. We create a 4-tube panel with 9 different antibodies, which was very successful, and we use it for more than 15 years. And we changed the gating strategy for light scatter gating to light scatter and combined light scatter and surface microgating. All these results in increased sensitivity, but the specificity stayed the same. To verify our approach, we perform a study in 145 cases. Here are our sensitivity and specificity for lymphoma diagnostic, and you see that the results were good and comparable to the results published at this period of time in the literature. At present, our diagnostic approach of lymphoma based first on microscopic examination of Giemsa stain smears. Then, in most cases, we perform immunophenotypic analysis by 10-color flow cytometer, and very rarely also by immunocytochemical method. In Some special cases, especially when we suspect T-cell lymphoma, we also use gene rearrangement studies for clonality analysis and FISH analysis. You may ask why we must use expensive ancillary techniques. The reason is that morphological features in reactive lymphocytic proliferation and lymphomas could be very similar. Here you see two cases, which is lymphoma and which is reactive. Moreover, different histological types of lymphomas might be indistinguishable on the basis of morphological features alone. Which of these cases is chronic lymphocytic leukemia? It's difficult to say. That's why we use ancillary techniques. Which information we can get from different ancillary techniques? By flow cytometric measurement and immunohistochemistry, we get information about cell lineage, clonality for B cells, and specific antigenic characteristic of lymphoma cells, which help us to classify lymphomas. With gene rearrangement studies, we determine clonality of B and T cells. Fluorescent in situ hybridization is helpful in some cases with specific translocations, such as follicular lymphoma, mantle cell lymphoma, or anaplastic large cell T-cell lymphomas. Now we have also two new very promising methods. One is next generation sequencing, and the second is methylation and analysis. All these techniques can provide a lot of information about tumor cells, also from very few cells. Therefore, I believe that in the future also these methods will be very helpful in cytopathology, especially in the field of the lymphomas. There are two main aims of final aspiration and cytopathological examination in lymphoma diagnostic. First, we must decide if we are dealing with lymphoma or reactive lymphocytic proliferations. And second, when we diagnose the lymphoma, we must try to classify a lymphoma. For the differentiation between reactive lymphocytic proliferation and lymphoma, we must first consider clinical and morphological features, and in difficult cases, perform also clonality analysis. For B cells, we suggest to use flow cytometry, and for T cells, gene rearrangement studies such as Biomet2 method. Reactive lymphocytic proliferations in histology are divided in two groups, in non-specific and specific cases. Non-specific cases in histology present as follicular hyperplasia, paracortical hyperplasia, sinus histiocytosis. These morphological pictures are not specific, and from this picture we cannot determine what is the cause of this proliferation. On the other hand, specific lymphocytic proliferation has such a specific cytopathological and also histopathological morphological features that we can define the type of lymphadenitis and also in many times the cause of the disease, such as in granulomatous lymphadenitis, Kikuchi disease, some viral lymphadenitis, and so on. On general, morphological features of non-specific reactive lymphocytic proliferations are quite typical. The cytological picture is polymorphous, in contrast to the monomorphous picture in lymphomas. In Gimza and Papanicolaou smears, lymphocytes predominate in different stage of differentiation. That means that we observe centroblasts, some mature small lymphocytes, some medium-sized cells, which belong to centrocytes, monocytoid cells, and so on. Reticulum dendritic cells can also be observed, some plasma cells, macrophages, and also capillaries. Morphological feature of specific reactive lymphocytic proliferation usually allow diagnosis of specific type of lymphadenitis. For Kikuchi's disease, crescentic histiocytes are typical. However, in many cases, only few are present or also absent. In Castleman disease, large atypical reticulum dendritic cells can suggest a diagnosis. When we see epithelioid granulomas, we should think about granulomatous lymphadenitis. Empyropolesis is suggestive for Ruseid-Dorfman disease, and Reed-Strenberg-like cells can be seen in lymphadenesis, which is caused by virus infection. However, we must be also aware of diagnostic pitfalls. When we see in cytological smears epithelioid granulomas, our first differential diagnosis is, of course, granulomatous lymphadenitis, which can be observed in all these diseases listed here. However, don't forget, epithelioid granulomas can also be found in Hodgkin lymphoma, T-cell lymphomas, or B-cell lymphomas. The same is with Reed-Strenberg-like cells. These cells are quite similar, but two cases are lymphoma cases, and one case is lymphadenitis caused by EBV infection. The morphological features of reactive lymphocytic proliferations and lymphomas is in many cases very similar. So only by morphological examination is difficult to say which case is lymphoma and which case is reactive. In these difficult cases, or when we cannot decide on cell morphology, we must use ancillary techniques. For differentiation between reactive B lymphocytes and B-cell lymphomas, flow cytometry or PCR-based clonality analysis can be used. Flow cytometric method, determination of clonality by flow cytometric method is based on determination of the ratio between surface light kappa and lambda change. When the ratio is low, this is in the favor of reactive lesion. Where the ratio is high, this is in favor of lymphoma. These are the results of a PCR-based clonality analysis. Here you see a polytypic polyclonal pattern, which is consistent with reactive lesions, monoclonal pattern, which is consistent with lymphoma, and monoclonal peak in reactive background, which in our, according to our experience is more in favor of a reactive process. But the question is, which method should be used in cytopathology, flow cytometry or PCR-based clonality analysis? To answer this question, we perform a prospective study where we include 82 cases of B-cell lymphoma and 62 cases of reactive lymphocytic proliferation. At this cutoff points listed here, the flow cytometric method was most sensitive and specific, and in comparison to Biomet 2 method, it performed much better. The problem of PCR-based clonality analysis BioMet2 is that the specificity is too low because there is too much false positive results, which is also described in the literature. So for B-cells, we recommend to use flow cytometric immunophenotyping. But what to do when the ratio between kappa and lambda light chains cannot be determined? You see here some strange surface light change results. There are cases where surface light change are negative, not expressed. There are cases where they are double positive. That means that in cells both light chains are detected. And there are some strange results where it's difficult to calculate this ratio between light change. We call this light chain expression inconclusive surface light change. What is the clinical meaning of these results? To answer this, we performed a study where we included about 142 cases. There was about 159 cases with negative surface light change, about 47 cases with double positive light chains, and 14 cases where the light chains were difficult to interpret. With the red dot you see is the percentage of lymphoma cases in these groups, and you see that in double positive group there is about 90% of lymphoma cases, and this percentage was also high for difficult to interpret cases. But in negative cases there were only about 45% of lymphomas. There were some data in the literature that BCL2 test and cytoplasmic light change test can also be used to determine clonality of B cells. So we want to test if these two tests can be used as a triage of these patients and to determine which patient has lymphoma and which not. Here are the results of these tests of the sensitivity and specificity, the results of single cell tests, and also the combination for all these three groups of inconclusive surface light change. And you see that for the group with negative light change, only BCL2 test is enough because the sensitivity and specificity is practically the same as when we use combined tests. But for double positive and difficult to interpret group, the best results are obtained when both of tests are used. The differentiation between reactive T lymphocytes and T-cell lymphoma is, in my opinion, the most challenging in cytopathological lymphoma diagnostic. Here we must rely in everything. In morphology, with flow cytometer, we try to determine aberrant expression of T-cell markers. And finally, in most cases, the diagnosis can be confirmed only by clonality analysis using gene rearrangement studies. The second aim in cytopathological lymphoma diagnostic is classification of lymphoma. This aim is most probably the most controversial. Histopathology, as you know, is still the golden standard for classifying of primary lymphomas. For the classification, WHO classification of hematopoietic and lymphoid tissue neoplasm from 2016 is used worldwide. The role of cytopathology in classifying lymphomas is controversial and not established yet. From the data from the literature and also according to the opinion of different experts, the cytopathological examination of lymphoma is nowadays accepted for diagnosing lymphomas in fluids, for staging, evaluation of treatment response, confirmation of recurrent disease, and confirmation of transformation of small cell lymphoma to aggressive large cell lymphoma. However, it is very controversial in primary diagnostic lymphoma, classification of lymphomas, and also for the determination of prognostic and predictive factors. We believe that fine needle aspiration and also cytopathologic examination can have a very important role also in primary diagnostic of lymphomas. It can be used as a screening tool for the differentiation between the reactive and neoplastic lymphocytic proliferation. By this approach, we can define the most representative lymph node for the excision biopsy, and we also decrease the number of unnecessary excision biopsies. In addition, this approach allows treatment decision in patients where biopsy and histopathological examination cannot be performed. As in histopathology, also in cytopathology, we must use for the diagnostic approach criteria from WHO classification of lymphoid neoplasm. According to this classification, we divide lymphomas in 4 big groups. First is precursor lymphoid neoplasms, where we put B-lymphoblastic leukemia and lymphoma and T-lymphoblastic leukemia and lymphoma. The second big group are mature B-cell lymphoma, which can be divided in 2 big groups. The first group is a group which is consisted of lymphoma with small cells. It is called small cell B-cell lymphoma. These lymphomas are mostly indolent. And the second group are lymphoma composed of large cells, so-called large cell lymphoma, which are aggressive. The third group are mature T-cell and NK cell lymphomas, and the last group are Hodgkin lymphomas. Precursor lymphoid neoplasms can be accurately diagnosed by cytopathological examination when it is supported by immunophenotypic, especially flow cytometric analysis. Here you see the smear of B-cell and T-cell lymphoblastic leukemia and lymphoma. Most probably you agree with me that the morphological features are the same, so only on the basis of morphology distinction between B-cell and T-cell lymphoblastic lymphoma leukemia is practically impossible. That's why with flow cytometry we define cell lineage and also define some subtypes of this disease. The lymphoblasts in acute lymphoblastic leukemia and lymphoma are not the only blasts we see in fine needle aspiration cytology smears. We can also see different blasts in different lymphomas and also blasts in acute myeloid leukemia. Here are different blasts. Can you tell me which blast belongs to lymphoblastic lymphoma leukemia? Without immunophenotypic analysis, I think this is practically impossible. And you see that here we have blast of mantle cell lymphoma, blastoid variant. Then we have blast of acute myeloid leukemia, blasts in diffuse large B-cell lymphoma, and so on. The second very important group of lymphomas, which are the most frequent in Western countries, is mature B-cell neoplasms. And first I will talk about small cell B-cell lymphomas. This is a group of lymphomas where belongs follicular lymphoma, mantle cell lymphoma, marginal zone lymphoma, chronic lymphocytic leukemia, small lymphocytic lymphoma, lymphoplasmacytic lymphoma. These lymphoma in cytology are morphologically very similar. I have already presented this picture, and you see it's difficult to say which one is follicular lymphoma, which one is mantle cell lymphoma, and so on. Helpfully, these lymphomas have specific immunophenotypic features, and mantle cell lymphoma and follicular lymphoma has also specific translocations which can be determined by FISH. Using data about immunophenotype and also translocation help us to classify these lymphomas reliably also in cytopathology. Sometimes we have problems with CD5 positive small cell B-cell lymphoma. In the differential diagnosis, we should consider mantle cell lymphoma, splenic marginal zone lymphoma, and CD23 negative chronic lymphocytic leukemia. However, with cyclin D1 staining and determination of CD20, we can resolve these differential diagnostic problems. But what about grading of follicular lymphoma in cytopathology? Most of the people believe that this is not possible. In the literature, you will find publications that they try to grade follicular lymphoma with microscopic examination, with counting the centroblast. This approach turned out not very satisfactory. There are also described some flow cytometric methods when they compared the large lymphoid cells, which should be centroblasts, to normal T-lymphocytes, and these methods are very promising. In our laboratory, we tested one of these flow cytometric methods. In 75 cases of primary follicular lymphoma, and we defined a cutoff point of 50% of large cells, which divided follicular lymphoma in follicular lymphoma with low cytological grade and follicular grade with high cytological grade. This grading correlates quite well with histological grade, but it was interesting that it was when we performed survival analysis that there was significant difference in survival with follicular lymphoma patients with low and high cytological grade. When we use multivariant analysis, this result was still valid for the patient younger than 60 years. But for histology grade, no difference in survival was obtained for the same group of the patients. In some difficult cases, also MIP1 staining can be helpful. Now I would also like to mention something about plasma cell neoplasms in cytology samples. We don't see them very frequently because this is mostly the bone marrow disease. However, we must be aware of this disease, especially also about the differential diagnosis, about which I will talk later. Neoplastic plasma cells can be mature, practically the same as normal plasma cells. Immature, they have larger vesicular nuclei with prominent nucleoli, then can be binucleated, then can resemble plasmablast, or they be quite anaplastic. In these smears, we can also observe Mott cells, Dutcher bodies, Russell bodies. However, these features are not pathognomonic. It is important to remember the phenotype of neoplastic plasma cells, which can be determined immunocytochemically or by flow cytometer. typically is that it expresses plasma cell markers CD138 and CD38. The B-cell lineage markers are negative. Also surface light change. The CD65 and cyclin D1 are aberrantly expressed, and cytoplasmic light change are restricted. Why this is so important? Because in the differential diagnosis of plasma cell neoplasms in final aspiration samples are some B-cell lymphomas. Therefore, this is very important. In the differential diagnosis, we should consider B-cell lymphomas with plasmacytic differentiations such as lymphoplasmacytic lymphoma, chronic lymphocytic leukemia, marginal zone lymphoma, then plasmablastic lymphoma, anaplastic lymphoma, and carcinoma. For B-cell lymphoma with plasmablastic differentiations, the important differentiation is that these lymphoma express lineage B-cell markers such as CD19 and CD20. Plasmablastic lymphoma has the same phenotype as plasma cell neoplasm, but are either positive. Anaplastic lymphomas have positive B-cell or T-cell lineage markers. However, in the differential diagnosis, we should also consider carcinoma, which could be resolved with pancytokeratin staining. The second big group of lymphoma in the group of mature B-cell lymphoma are large B-cell lymphomas. These lymphomas cannot be classified on cytopathology, but the important message is that most of them have the same treatment. There is no difference in treatment. The only lymphoma which is treated nowadays, according to guidelines differently, is high-grade B-cell lymphoma with MIG and BCL2 and or BCL6 translocation. Since we can use this in cytology, and if we have a problem that the only cytopathological diagnosis is available, we can distinguish this large B-cell lymphoma from other histological types of large B-cell lymphomas. The most common among these large B-cell lymphomas is still diffuse large B-cell lymphoma, not otherwise specified. It is composed of large B-lymphoid cells. It has diffuse growth pattern, but what it is important is definition of large B-lymphoid cells. In the WHO classification, it's written that large B cells has nuclear size equal or exceeding normal macrophage nuclei or more than twice the size of normal lymphocytes. This definition is also helpful in cytology when we are not sure if we are dealing with small or large cells. Three most fragment centroblastic, immunoblastic, and anaplastic variant are most common variants in diffuse large B-cell lymphoma, not otherwise specified. However, these morphological variants are not clinically important. In cytopathology, we cannot distinguish between diffuse large B-cell lymphomas and high-grade follicular lymphoma. However, the treatment of both types of lymphoma is the same, so this the differentiation is not relevant at the moment. In our hospital, therefore, for these two groups of lymphoma in cytopathology, we use term large B-cell lymphomas. What about the prognostic factors in diffuse large B-cell lymphoma not otherwise specified? In the literature, different prognostic factors are described. However, the results of different studies are very controversial. Therefore, treatment decisions are still not based on the determination of these prognostic factors, so it is not necessary at present to have possibility to determine them also in cytopathological samples. Burkitt lymphoma is an urgent diagnosis. What does it mean? It means when we suspect the Burkitt lymphoma, we must make a diagnosis in a few hours because we must start to treat at once. This diagnosis is possible also in cytopathology if we consider typical cell morphology, that's mean medium-sized blasts with a scant basophilic cytoplasm, which contain vacuoles, oval to round nuclei with multiple nucleoli, numerous mitotic features, apoptotic bodies, and sometimes also starry sky can be seen. The immunophenotype must be typical, proliferative activity must be 100%, and to be sure that we are dealing with Burkitt lymphoma, we must perform also FISH. Typically, MIAC translocation is present, however, BCL2 and BCL6 translocation must be negative. If all this fits, then also in cytopathology, we can make an accurate diagnosis of Burkitt lymphoma. The most challenging group to diagnose in cytopathology, by my opinion and my experience, are mature NK T-cell lymphomas. Some are well described in cytopathological literature, such as anaplastic large T-cell lymphoma. However, a lot of them are poorly described and their morphological features overlap with reactive lymphocytic proliferation. In lymph nodes, the most common T-cell lymphoma in Western countries are peripheral T-cell lymphomas and angioimmunoblastic T-cell lymphomas. Anaplastic large T-cell lymphoma is well described in cytological literature. As in histology, 3 variants are described: common, small cell, and lymphohistiocytic. The diagnostic cells are so-called hallmark cells. These are big lymphoid lymphoma cells with basophilic cytoplasm, horseshoe or kidney-shaped peripheral located nuclei. In common variant, predominate these large lymphoma cells. In small cell variant, the lymphoma cells are not typical. They resemble immunoblast or centroblast and can be overlooked. In lymphohistiocytic variant, the reactive lymphocytes and histiocytes predominant, and only few hallmark cells can be found. To highlight the lymphoma cells, the CD30 immunohistochemical staining is very helpful. And also ALK staining must be performed to differentiate between ALK positive and ALK negative cases. Here you see the different morphological types of lymphoma cells in anaplastic large T-cell lymphomas. Beside these typical hallmark cells, we can also see donut-like cells, monomorphic cells, and Reed-Strenberg cells. What is also very important is that a lot of mitotic features can be observed in these smears. Now, a few words about NK T-cell lymphomas, which are poorly described in cytopathology. The problem is that this lymphoma has unspecific morphological features which overlapped between different T-cell lymphomas. In some cases, immunophenotypic characteristics allowed classification of these lymphomas, for example, in hepatosplenic gamma delta T-cell lymphoma. However, in most cases, the classification in cytopathology, in my opinion, is not reliable. We believe that maybe with molecular classification, with next generation sequencing, this classification will be also possible in cytopathology, but also in histology, this classification is still not accepted, and there is a lot of research in this field. The last category is Hodgkin lymphoma. Two types of Hodgkin lymphoma are in this group. First is nodular lymphocyte predominant Hodgkin lymphoma, and the second one is classical Hodgkin lymphoma. In cytopathology, the subtypes which are prognostically important of classical Hodgkin lymphoma cannot be diagnosed. Nodular lymphocyte predominant Hodgkin lymphoma is one of the most difficult diagnoses in cytopathological lymphoma diagnosis. The reason is that LP neoplastic cells, which are called lymphocytes predominant or popcorn cells, some kind of variant of Reed-Strenberg cells, are usually very few in the smears and very inconspicuous and can be overlooked. They are mixed with reactive small lymphocytes, histiocytes, epithelial granulomas, and reticulum dendritic cells. The problem is also that they don't have specific immunophenotype. They don't express CD30 and CD15 as in classic Hodgkin lymphoma, but are CD20 positive. Here are some images of these LP cells, and you see they resemble reticulum dendritic cells, and it is possible that we just think that we overlook them. In classical Hodgkin lymphoma, the diagnostic cells are Reed-Strenberg cells and Hodgkin cells, which are well defined in histology, and also the morphology is the same in cytology samples. These cells are mixed with reactive background cells, such as small lymphocytes, eosinophils, neutrophils, plasma cells, and histiocytes. The immunophenotype is quite typical. CD4 tumor cells are CD30 and CD15 positive, rarely express CD20. In histology, nowadays also PAX5 and MUM1 is used, but we don't use these markers yet. These are some picture of classical Reed-Strenberg cell, a Hodgkin cell, and some slightly atypical cell which resemble Reed-Strenberg cells. Sometimes only these cells can be found in final aspiration cytology smears. As you see, the classifying of lymphoma and cytopathology is challenging and difficult. So the question is, why classifying lymphoma and cytopathology? I think that we must do that because the cytopathological sample can be the only available sample for the diagnosis. If we are not experienced in diagnosing lymphoma, we will not be able to diagnose lymphoma only if we don't have enough experience. In addition, cytopathological examination provide information about lymphoma diagnosis in few hours, and also allow planning further diagnostic, and in some cases even beginning of treatment before the results of histological examination are available. How good we are in classify lymphoma? There is a very few data about this in the literature. Here I will present you a pilot study where we try to see how good we are in classifying a lymphoma when we use one tube 10 color panel, antibody panel, when we use 10 different antibodies, kappa and lambda line chains, CD5, CD19, CD20, CD3, CD23, FNC7, and CD5. I don't see. We classify 38 cases, and you see that when we compare to histology diagnosis, there were difference only in 5 cases. 2 cases was suspicious for lymphoma. There was the problem because the quality of sample was poor, that results of ancillary techniques were difficult to interpret. And there were 3 cases which are not difficult only in cytopathology, but also in histopathology, and that in the end it is not quite clear which diagnosis is the correct one. We can say at the end that classifying of lymphoma in cytopathology is at present not satisfactory. It is accurate only in lymphoma types with specific cell morphology, immunophenotype, or molecular features. And it is not possible in lymphoma types which are defined by architectural features such as nodular lymphocyte predominant Hodgkin lymphoma, T-cell rich B-cell lymphoma, and so on. To conclude, cytopathological examination allows accurate differentiation between reactive and neoplastic lymphocytic proliferation. Classification of lymphoma in the extent which allows treatment decisions according to the current guidelines is possible. Also, the determination of predictive factors, which are important to planning the modern treatment. However, we believe that cytopathological examinations must be included in multidisciplinary lymphoma diagnostic. However, further studies are necessary to improve cytopathological diagnostic of lymphoma in the future. Here is our algorithm how to make a diagnosis when we are dealing with the patient which have a clinical suspicion for lymphoma. First, we examine the Giemsa stain smear under the light microscope, and we compare the morphological features with clinical data, and then we divide on the basis of these results the patient in 3 groups. The first groups are the patients which are consistent with reactive lymphocytic proliferation. In report, we make a report usually without recommendation. In some doubtful cases, we recommend that infection must be excluded, or we suggest a follow-up final aspiration after 4 to 6 weeks. In the second group are cases which are morphologically suspicious for Hodgkin lymphoma, anaplastic large cell T-cell lymphoma, or the flow cytometric results are inconclusive, and here we perform immunocytochemical staining. In the third group are the patients which are clinically and morphologically suspicious for B or T-cell lymphomas. Flow cytometry is first performed, and in difficult cases, sometimes also clonality analysis with molecular techniques, FISH, or immunocytochemistry. In all cases where cytological diagnosis is lymphoma or suspicious for lymphoma, biopsy and histology is performed. At the end, I would like to thank to my co-workers and also to my family who support me in my research and clinical work. Without them, I think I will not be able to perform all this work in lymphoma. And at the end, thank you for your attention. And don't forget, we can do in cytology as good as in histology. Thank you again.
Thank you, Veronika. That was excellent, beautiful photographs. Very well done, very concise. Hard to cover such a large topic in an hour, but you did spectacularly. And I agree completely with the sentiment that cytology certainly can't solve all the world's problems. We have to acknowledge its limitations. As long as we do that, we can convince people of its usefulness. There are already some questions from the audience that I will read. However, I do invite any other participants who might have questions to put them into the QA window or possibly the chat box. Just if you use the chat box, be sure you're sending the question to me or to everyone and not strictly to the speaker who may not see it. The first question is, are you considering using single layer cytology slides at initial diagnosis instead of smear slides?
Can you repeat the question?
Sure. Are you considering using single layer cytology slides at initial diagnosis instead of smear slides? I think they may be referring to possibly liquid-based preparations or thin layer. We can always clarify that the question is single layer cytology slides.
I think that smears provide us more information because when we are dealing with liquid-based cytology, the slides which are prepared by machines or by cytocentrifuge, there is a lot of artifacts. And the problem with this liquid preparation by slide processor is that you cannot use Ginza. I think in hematology, the classical staining, not only in cytopathology, but also in histology, is make Ringwald Ginza for lymph nodes, for bone marrow, histology samples, and also for all cytology sample. And I think that currently the best results can be obtained only by examining smears. There is not problem with in lymphomas with the cellularity of the samples because in our experience, in our final aspiration clinic, and also our radiologists are quite good. They usually obtain about 2 million cells, which means that it is enough for all ancillary techniques, and this number of cells is left when we have already performed the smear. So I think that liquid-based cytology is not good for preparing the slides for microscopic examination, that more information is obtained by classical smears.
Great. Another question is, what is the mean turnaround time of the cytopathologic diagnosis, including immunocytology and other examinations in accordance to the assumed cytologic diagnosis?
I think that most diagnoses are finished in 24 hours. But if there is some emergency, such as, for example, Burkitt lymphoma, we can just perform final aspiration biopsy, and I think in 3 hours we can have a diagnosis without fish. But if when we want to perform also the translocation, we need another day. So I think it depends what kind of working flow you have. In our department, it's the practice that one day we collect the samples. They are prepared for microscopic examination and stained. The next morning, the pathologist gets the samples, and the flow cytometry is in 2 hours.
Thank you. The next is more of a comment, but I want to read it to you because you may not see it. The comment is, thank you, Veronika. Impressed with your practice and experience. Very nice presentation. Lots of work still to do to gain more widespread acceptance for cytology, for the cytologic diagnosis of lymphoma. Another question is, thank you for your excellent and straightforward lecture. This is a pathology resident from Southeast Asia. We usually use diff-quick stain. Is it advisable?
Yes, it is advisable. I think that any Giemsa stain, it's okay. The most important is that all Giemsa stains are quite difficult to perform. It is difficult to have a high quality Giemsa stains. So I think that any Giemsa is okay. It is the high quality, because if you have one Giemsa stain with good quality, then you can really make a good diagnostic criteria and your diagnosis will be okay. I think this is important.
Great. There's one more question. It's from the same person asking the last question, the resident, for their second question. Unfortunately, they have no flow cytometry available. How far can you make a diagnosis with only a smear and with cell block-based immunohistochemistry?
I think the cell block immunohistochemistry is quite good, especially if you are also experienced in histopathology. However, we believe that flow cytometry is much faster. We are dealing with unfixed cells, and also the results are more, how to say, quantitative, not so qualitative, when we interpret immunocytochemistry and cell blocks, there is a lot of inter-observer variability. I'm not so sure how surface light change work, because these are crucial to say if it is lymphoma or not. From our experience, surface light change in histology don't work well, even in reference centers. So for cytology, and to answer the first question, if it is reactive or lymphoma, it's the most reliable flow cytometer. Nowadays, you can perform this really with a very low cost. Our one tube panel, where we put 10 different antibodies, is about 100 euros, which is not so expensive if you consider that you will avoid surgical biopsy, histological examination, and so on. And you are sure and safe that the patient have reactive lesion. I think this is very important.
There's another question, and the question is, do you use Euroflow?
No, we don't use Euroflow because Euroflow is not a flexible approach, At that time, when we start with flow cytometry, there was no Euroflow. We started by ourselves. During our history, we learned a lot, and I think that Euroflow is too rigid. It's too rigid. The problem is that at the beginning they promised that they will have a lot of this a big database in the cloud, and that it will be possible to compare your samples to the results in the cloud. But unfortunately, this was not realized. So if you're not experienced in flow, you will make also problems if you will use your in-house protocols or Euroflow. So, but the panels of Euroflow are quite good.
Great. There is a question asked, do you use liquid-based cytology for ICH?
ICH, what is ICH?
I'll wait for the participant to possibly clarify the question. I know you had just answered a little bit about liquid-based cytology in general from the first question. So while I wait for possible clarification or for additional questions, I just want to thank the participants for being so engaged in asking good questions. And if you came in a little bit late or want to review the lecture, it should be archived. The speaker is allowed it to be archived within the proprietary format of the system. So hopefully you'll be able to review it within the next day or two. So with that, I'll just wait another brief moment to see if there are any additional questions. And otherwise, thank you very much, Veronika. It was excellent. I think I'll actually be reviewing it a couple of times myself.
Okay, thank you, Christopher, for inviting me. It was a great time to share all these my ideas and knowledge with the people. Thank you for your attention again.